Health disparities is such an important topic in all aspects of our life. But I could make the case that multiple myeloma is actually the most disparate cancer within the African American community. Not only do we know that myeloma is twice as common in the African American community, sadly, the most striking fact is that mortality is twice as high also in the African American community when compared to white Americans. This is simply unacceptable, and we have to find ways to reduce that health disparity. We know that African Americans are in fact less likely to have high-risk multiple myeloma and are more likely to have standard-risk myeloma by the presence of things like the translocation 1114. This actually makes the disparity greater, as we would anticipate based on that biology that African Americans would have a longer survival with multiple myeloma. Myeloma-specific health disparities include delayed diagnosis. We know that the average patient sees their primary care provider 3 times with signs and symptoms consistent with myeloma before myeloma is diagnosed. That delay is even longer within the African American and Hispanic communities. Much of that has to do with trust in the healthcare system, access to the diagnostics, and access, frankly, to primary care. So delayed diagnosis is a big driver in health disparity in multiple myeloma, but as is access. And access may be the greatest disparity. We know, for example, from large VA studies that when individuals are given the same access to therapies, as we would expect in the VA, that patients independent of race and ethnicity would have the same access to therapies, that African Americans actually have a superior survival to white Americans. But sadly, this is not true in real world evidence and in real life. And reducing that disparity becomes absolutely fundamental. That access is manifest in multiple arenas. We know that there are multiple treatments and approaches that have changed survival of myeloma. Often I summarize them with the 4 T's of access. Triplets, meaning 3 drug combinations that we know are superior to 2 drug combinations. And sadly, African Americans are less likely to access triplets. Transplants or autologous stem cell transplants. We know that transplants significantly prolong progression-free survival in patients, and unfortunately we do see reduced access to transplants within the African American community and also within the Hispanic community. The 3rd T is clinical trials. Not only do we know that clinical trials pave the way to new therapies, they clearly have an impact on patients' outcomes. And for a whole host of reasons, African Americans are less likely to access clinical trials. Indeed, in our myeloma world, African Americans comprise somewhere around 6% of participation in all clinical trials, whereas African Americans account for approximately 20% of all myeloma patients. And the last T is the most recent T, CAR T-cell therapy. This is really a tremendous new modality that we have in myeloma that has had unprecedented response rates, and again, unfortunately, has been less accessible to those with lower socioeconomic status and African Americans. Putting this all together, we see a tremendous health inequity in multiple myeloma in African American patients, and why it's so important for us to be dedicated to the multi-level solutions that will be required to reduce this health inequity. As I've described, the health disparity in multiple myeloma is incredibly complex, and so it is going to take complex solutions. But specific to multiple myeloma, in that delayed diagnosis and reduced access, it is critical that we engage this community. And that deep community engagement, both in the medical and the non-medical world, to raise awareness around multiple myeloma so that those early signs and symptoms can be understood, so that patients can go see their primary care providers to see whether or not they have multiple myeloma, is really going to be important. This is not a short-term strategy, but a long-term strategy. But also, we need outreach into the medical community, into the primary care community, to educate so that we can know what are those early signs and symptoms of multiple myeloma, so that we know how to make a timely diagnosis with the right diagnostic testing. And then lastly, within the hematology oncology community, to recognize that we want to provide the most culturally sensitive and appropriate care possible, that we reduce all of those barriers that have historically kept individuals from accessing the healthcare system and accessing the treatments that we know can improve their lives with multiple myeloma.